Good afternoon. I am Sarah Dash, President and CEO of the Alliance for Health Policy. Welcome to the fourth event in our COVID-19 webinar mini-series. As COVID-19 continues to spread, frontline health workers are at high risk of becoming infected themselves. Today, our panelists will explore steps necessary to protect these workers. The Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for their support of today's webinar. You can join our conversation on Twitter using the hashtag AllHealthLive and follow us at AllHealthPolicy. And the Alliance is here as a resource during this rapidly evolving crisis. If you have unanswered questions or ideas for programs that you would like to hear, please share them with us. We want to hear your questions today, so I'm going to briefly orient you all to the GoToWebinar platform and quickly review some technical notes. You should see a dashboard on the right side of your web browser. Select the speech bubble icon with the question mark to chat with us about any technical issues you may be experiencing. And you can use the second speech bubble icon to submit questions that you have for the panelists at any time. We will collect these and address as many as we can during the broadcast. Later today, you will also find all of our materials on our website and a recording of today's webinar. Now I am pleased to introduce today's panelists. We're joined today by Dr. Stephen Parodi, who is the Executive Vice President of External Affairs, Communications, and Brand at the Permanente Federation and the Associate Executive Director of the Permanente Medical Group. Dr. Parodi is a practicing infectious disease physician by training who is at the front lines of the outbreak in California. Next, I am pleased to introduce Dr. Polly Pittman, who is the director of the Milken Institute for Health Workforce Equity at the George Washington University's Milken Institute School of Public Health. Dr. Pittman oversees an extensive research enterprise focusing on policies that enable the health workforce to better address health equity issues. Her portfolio includes directing 2 HRSA-supported research centers. Steve and Polly, thank you both for joining us today.
Thank you for having me.
Thank you. Let me start with a couple of questions. First, let me open up with a question for Polly. As COVID-19 continues to spread, frontline health workers face the highest risk for being infected themselves, or one of the highest risks. What are the issues at the top of your mind to protect health workers?
Well, I mean, we have, to some extent, a situation of a lot of confusion and improvisation right now, particularly with the shortage of protective gear. So I would say that my major concern right now, based on what we've seen in countries around the world, not only during times of pandemic, but just countries that face chronic shortages of health workers, that there's a danger of sort of getting into a downward spiral, a sort of a vicious cycle where you have the lack of training, the shortages in terms of protective gear, weakening of guidelines and confusion about the guidelines at the national level, creating sort of a difficult context in which you're already facing a whole sort of cascade of potential absences from the workforce, starting with the fact that a large number of our nurses, for example, are older and may not be able to present to work. The family needs of the workers themselves, whether they are due to childcare or because someone's sick in the family. I mean, of the 18 million health workers in this country, 80% are women. So you're talking about a lot of mothers and grandmothers, some even great-grandmothers in the nursing workforce. So you have that level, and then you have the exposure and a lot of differences across the country in terms of sort of what the protocols are in terms of quarantine. Then you have the actual infections, which may be as high as 12% based on other countries. And then you have, God forbid, you have death also of health workers. So essentially you have the threat of a lot of absences as a result of the problem. And that obviously results in moral distress in the remaining workforce, fatigue, and low morale. And so you get a situation where that in turn can contribute to more absences. And that's what we call in health workforce planning sort of a downward spiral that feeds on itself. So that is not occurring right now, but that is the danger.
Thank you, Polly. So to Steve, you operate at Kaiser Permanente in some of the states that are most impacted by the outbreak, including California and Washington. Can you tell us a little bit about what is happening on the ground and what steps is Kaiser Permanente taking to protect healthcare workers amidst the surging or about to surge number of cases?
Yes, I can definitely speak to that. So we actually had an early experience because of the work that we did to support the Princess Cruise evacuees from Yokohama in February. And that actually gave us the experience for providing care within the hospital setting and also containment strategies, and quickly understanding that we needed to move to a mitigation strategy given the spread of the virus in the communities. And so we have taken a number of steps, both in Washington State as well as California early on, but now throughout the country to implement several different interventions. So one is tailoring the personal protective equipment for how the virus is spread, and it is primarily spread in the community by droplets. So moving towards enhanced precautions that protect the healthcare workers with the gowns, gloves, goggles, and the right surgical masks to preserve the N95 respirators for aerosol generating procedures was an initial early step. The second thing we did was we recognized that there were supply chain shortfalls because of the manufacturing crisis in China. So we implemented CDC guidelines for reuse, extended use of N95 respirators early on. The second thing we did was we actually implemented telehealth in a huge way. So that allows for a reduction of foot traffic through our medical office buildings and increasingly through our emergency departments. And just to give you the latest statistics that we're seeing, we have reduced the number of primary care visits by 90% in the last week. We have also reduced the number of subspecialty visits by now 50%. So what that means is that we now have a large amount of our workforce that can actually work from home and contribute to the social distancing efforts that are really critical to reducing the amount of spread in our community and also in our healthcare facilities. We turned off elective surgeries more than a week ago to reduce the volume of patients that are requiring intensive care as well as hospitalization for surgery. So that's allowed us to prepare for a future surge in the coming weeks. We have ramped up testing so that we have greater capability and understanding of the epidemiology, not only in the community, but also to increase hospital capacity and reduce the burn rate of personal protective equipment. So when you've got testing that can be turned around in 8 to 24 hours, that allows you to take somebody off isolation who doesn't need the enhanced precautions if they test negative. And if they test positive, we've got reasonable assurance that we can protect the workforce adequately. We're also taking steps to work with manufacturers to ramp up production either domestically or internationally in partnership with the federal and state authorities so that we can get more personal protective equipment available. The other thing I'll just mention is that we are working with hand in glove with our state authorities throughout the country to make sure that we've got other alternative evaluation sites and or places where we could do hospitalization. That includes tents. It includes other hospitals that currently aren't in use but could be brought up to speed and be in use. And actually working with National Guard, working with Department of Defense, where we could have mobile hospital units in place as well. So a lot of different efforts. This is a huge public-private effort that's going to require a prolonged response.
Great. Thank you so much, Steve. Well, so many follow-up questions, but one, just early on you mentioned this issue of moving from containment to mitigation, and I know you and your colleague wrote in the Journal of the American Medical Association just about 11 days ago that it's critically important to move from containment to mitigation. But for those who aren't maybe as familiar with that terminology, can you explain what the difference is?
Yes, so containment is really an initial strategy where if you can identify the cases or people that have the disease, you isolate them. And then you do aggressive contact tracing. So anybody who is around that person, you also isolate those individuals. And the idea there is that you are preventing any spread into the community and hopefully actually completely terminate the outbreak. And that's actually what was successfully done back in 2003 with SARS. And our initial strategy in the United States was to isolate these individuals in hospitals. And what became abundantly clear really towards the end of February is that we had ongoing community spread occurring, even despite the lack of adequate testing capability. And so once you have spread out in the community despite those containment efforts, you have to shift to directing your resources to minimizing the spread and actually using your limited personal protective equipment resources, your limited hospital resources, so that you're directing the right treatment to the right level of illness. And so that's really what an overall mitigation strategy leads us to. It essentially is, if you think of it, scaling a larger public health response because you've got a larger problem that goes beyond containment.
Great, thanks. So I'm just going to ask one more follow-up question before I turn to Polly again. So, you mentioned kind of really making the best use of limited hospital resources, scaling them up to where it's most serious. Earlier on, you mentioned CDC guidelines, reusing extended use of the personal protective equipment. And on the CDC website, they talk about different layers of capacity. They talk about conventional capacity, contingency capacity, crisis capacity, and they're pretty clear that sometimes in a crisis capacity setting, the use of the PPE or the personal protective equipment may not be in line with sort of our ideal standards of care. Do you think, do those guidances keep changing in light of the supply shortage? Do you think hospitals will ultimately be able to get the supplies that they need? What is that interaction like?
Yes, so I think that right now, having all of those options available to us is critically important. You see some of the early interface with the virus and what's happening in New York, and the ability to flex regulation, whether it's the hospital infrastructure, whether it's the personal protective equipment guidance, and whether or not we need to flex in terms of personnel and how they're being deployed. And I think we have to have all those levers in place because we are going to need to be able to, essentially, if you look at the models, when it comes to what a surge might look like, even with optimal mitigation strategies on the public health sector side, we're going to need to be able to increase hospital capacity by 2, 3, or more times to be able to provide the care. And we do need to be cognizant of, even if you haven't been in a locale that has been hit by the virus in a significant way, this is the time now to basically be on wartime footing for preserving that personal protective equipment. Our hope, based on the fact that China is starting to ramp up manufacturing, there are sites that are now beginning to come back online, that by late April, early May, we'll start getting resupply from China. But we've got to bridge that gap between now and then.
Great. Well, thank you. Thank you for that insight. So, and later I want to ask you about telemedicine, but I want to ask Polly, Steve mentioned expanding capacity through temporary tents or hospitals or just kind of building up that capacity. But even if you expand that, how do you staff them sort of from a workforce planning perspective? If we face that downward spiral, there aren't enough people. What are some ways to mitigate those potential provider shortages? Will people have to come out of retirement? What is being done around the country?
Right. So I think Steve spoke to sort of what healthcare organizations and even in the case of Kaiser Permanente, because it's vertically integrated, payers as well are kind of aligned there. But it's really interesting to think about what states can do, what accrediting organizations can do, what educational institutions can do, the licensure in particular is an important lever. So outside of the health system itself, you have all of these organizations that manage kind of the bureaucracy of the healthcare workforce. And much as Steve indicated, within the healthcare organization, we need greater flexibility at that level as well. So some of these measures, I think, are emergency fixes, and some are sort of things that we probably should have been working on all along and that are more long-term solutions. One of the things we should have been working on all along, but we need to emerge, sort of in an urgent sense, address now are issues around expanding scope of practice. That is done at the state legislature level. And for the most part, the public has been aware of the discussions around the expansion of scope of practice for advanced practice nurses. But there are also really important expansions available for pharmacists and for respiratory therapists and for clinical laboratory people, for paramedics, for LPNs, for CNAs. All of those kinds of members of the team can potentially do more when they're trained up. And so having that authorization for healthcare organizations to be able to use their personnel in that way is a really important lever. The second sort of large area is expediting licensing. And as you mentioned, we can do that with retired personnel, although they may be elderly and may be more at risk, and that may not be as advisable. But certainly there are a lot of health professionals that do not work in direct patient care that could be mobilized. And that may be renewing licenses, it may be issuing licenses across states in a temporary manner. There are also opportunities to use international professionals that may not be licensed in this country that could receive emergency licenses. And of course, there's the whole sort of army of students that are graduating this very year, nursing students, about 150,000. We have the physicians that are starting their residencies. There are all kinds of opportunities to mobilize that workforce with temporary licenses as well. You can have, for example, nursing students that haven't graduated could be operating as LPNs. LPNs that haven't graduated could be operating as CNAs, et cetera. So there's a lot of room for creativity there, but it involves leadership on the part of the licensure bodies in coordination with or in response to the needs of the healthcare organizations have. So those are two large areas, I think, where a lot could be done at the state level and at the licensure level.
Thanks. So, Steve, let me ask you, are you looking at sort of transferring skills or, looking at, areas of your workforce at Permanente Medicine who maybe haven't been as involved in critical care, respiratory care? I mean, are they going to have to amp up their skills? Like, how are you looking at kind of maximizing everybody's capacity?
Yeah, I couldn't agree more with a lot of the comments that Polly was making just now. So at the state and federal levels, getting the flexibility and suspension in the form of emergency declarations of some of the health codes so that we can move towards ratios that are probably going to be changed because of the surge, repurposing of staff that hasn't had the particular training to be able to provide that in-time training now before the surge occurs is critically important. And that includes every single discipline, whether it's physicians, nurses, respiratory therapists, on down the line. We are actively developing plans for instance, knowing that there's going to be a need for more critical care. Being able to repurpose critical care physicians so that they can provide consultation on a telemedicine basis to multiple hospitalists. They're going to be repurposed as essentially, think of them as residents that are doing critical care. And then repurposing other subspecialists to backfill the hospitalists. and having the adult family medicine physicians then backfilling the emergency department. So actually thinking through, what does that look like? What do the ratios look like for, again, a doubling or tripling of what would be a normal hospital census, and working in these different conditions that I was referencing earlier, and then repurposing the nursing workforce and training them up and working at these different ratios, and then having extenders do some of that work as well. If you think about it, what we're finding with the telemedicine work on the outpatient side is that we're going to have a found workforce. So before even moving to the retired workforce, taking your existing workforce that is, right now in the moment, they have the training, they have the licensure, and then moving them to alternative settings that they might otherwise not have been doing before is going to be critically important. The other thing I just want to point out to you is this is not just a hospital-centric strategy. So we've got to be thinking about skilled nursing facilities, and what immediately comes to mind is the initial experience in Kings County up in Washington State, where a lot of the morbidity and mortality was centered around a particular skilled nursing facility. And so repurposing either the skilled nursing facility so that we can provide the care there with the appropriate PPE and or training, or actually using alternative sites like hotels to provide skilled care there, or post-discharge care out of a hospital is going to be critically important.
Thank you. And we're already getting some questions coming in from the audience, which is great. So please keep them coming. And Steve and Polly, as you're both talking, you're answering some of them. But just really quickly on this post-acute piece, or the post-discharge, how does that impact your ability to actually kind of move capacity through the systems if the post-acute settings aren't ready? Is that something that you're looking at?
Yes, and our early experience has been exactly that skilled nursing facilities and or just post-acute care settings are not inherently prepared to take care of this sort of complex need for isolation and just increased amount of infrastructure that needs to be in place. And so again, working with your state health systems is critically important to make sure that you've got those pieces in place. And again, it's infrastructure, it's people, and in many cases, if you think about it, and I'll just call this out, we have actually, again, other found capacity. A lot of ambulatory surgery units are now closed. A lot of other sites that are providing, outpatient procedural care are now closed. So taking that found staff and repurposing them for some of these skilled post-discharge needs is going to be important. And that requires, again, public-private coordination.
Great, thanks. So I want to turn to a question from the audience, which is about how we can ensure that frontline workers know the latest and most correct information, and how important is disinformation and confusion over COVID-19 in that regard? Polly, do you want to take a first crack at that question?
Well, I'm certainly hearing a lot of concern from frontline workers that are feeling as though, both from the perspective of the CDC guidelines and from the absence of sort of issuing new OSHA infectious disease specific standards, is distressing to them. I think, as Steve said, the fact that, the knowledge base is evolving very quickly. And so a lot of this is also at the level of the healthcare organization. And WHO has sort of issued a list of what they call health worker rights. And, foremost among them is just the right to be kept informed. And I think this issue of, continually, not even just the training, but just continually updating the frontline staff about sort of the, what is happening in terms of the science, what is happening in terms of the conversation about how the guidelines should be flexed, as Steve said. It's just really important to engage frontline workers in this and engage their representatives in it. And I think that I'm sure that Kaiser Permanente has a terrific relationship with their worker organizations, but not hospitals do, and there's more conflict. And I think there's a lot of distress, and particularly among the nursing personnel about this, perhaps less so among the physician staff.
Great. So Steve, are
Do you
there
mind
any
if I
practices?
chime in on that one? Because this
Yeah,
is a really important point that Polly's raising. So, when I have talked about the pandemic, there are really two pandemics that we're dealing with. There is one that is, of course, the one we've been just talking about, the virus itself. And then there's this other pandemic of fear. And, we've seen it in the community, and we see it, reported every night on the news. But, healthcare workers are not immune to it. And so there's a critical piece to being successful with this, which is communicating in a clear, honest, and direct fashion. And actually, we have learned that you need to do this via multiple modalities. So it's by video, it's by email, it's by in-person, and less so now because we're doing social distancing, but town halls. And in fact, later today, I'm going to be doing a town hall for all our workers to address exactly what Polly was talking about. They need to understand that we respect their rights, engaging with labor if you have active labor unions, and being clear and transparent with them is critically important. And then actually being honest about the fact that the data, the science is changing. And so being able to explain that in a clear manner is critically important. So I can't stress enough for all of you that are on the line that communications are clearly paramount, and you can't over communicate.
Thank you both for that question. So we've heard a lot about telemedicine lately, and Steve, you mentioned some of the ways you're using it. We've got a few audience questions about it. How are you using telemedicine, and especially, are there any remaining barriers to leveraging the power of telemedicine in this response? There have been some changes in the Medicare program, but what more needs to happen to fully take advantage of this technology?
Yeah, so I think that, I know there's still work being done at the federal level to open up even more avenues of being able to provide telemedicine across state lines. And of course, there are state level regulations that need to be dealt with. I think that the initial flexibility that has been provided is critically important. We're going to learn a lot, actually. Many of the traditional doctor office visits and or ancillary provider visits, advanced practice provider visits, I think we're going to learn can be done by telemedicine in the future. The other thing that I want to mention here is that what we've done, and I would encourage other health systems to do, is that a lot of the routine screening, the mammograms, the cervical cancer screening, the colon cancer screening, not the diagnostic procedures, but the ones that are screening, we've actually suspended those for now, again, to increase the social distancing as is possible. And for some of the colon cancer screening, you can do it still virtually. You can send them a fit kit or a card in the mail, and they can mail it back in rather than doing the colonoscopy. So you don't actually have to completely suspend things. So opening up our minds to more and different innovative ways of doing the care, I think is going to be important. The other thing I'll just call out here also is the ability to do video visits. So we're not just limited by telephonic means. And I have to say that we have seen an incredible uptake of this. So we've, over the last week, seen a 500% increase in the number of video visits that we're doing, welcomed both on the provider side and the patient side. So again, I think that we have not fully, we're just learning here. I mean, we're literally going to understand much better about what the practice of care delivery in medicine looks like coming out of COVID-19.
Great. Well, thanks. We have about 1 minute left. And so what I'd like to do is just ask each of you to maybe share one thing that we should be watching for in the next week as we all continue to watch this unfold. Polly, you want to start?
Yeah, I would say in particular, we should be ensuring that the nursing staff feel supported and appreciated by not just their employers, but the public at large. Oftentimes nurses are victims of even violence at the hands of patients. And this is a time where we really need to honor our health workers and express our enormous gratitude towards them. I think that would go a long way towards shoring up the emotional resources. I think there's a danger that there could be a mass exodus. People don't have to show up at work, and they won't show up at work if they don't feel supported and safe. So it's really important to be supporting our frontline staff.
Thanks, Polly. Steve?
And what I would say the thing we need to look out for is the public health response and continuing to bolster it. Last night when I got home, I heard some news reports that perhaps we should be thinking about backing off social distancing, backing off some of the critical public health measures. And so I think what we need to actually bolster is actually the opposite, that we need to double down on the work. Some of the comments I heard from the New York governor resonated with me, that, in fact, the social distancing is our first line of defense. We need to continue that. We need to ramp up testing so that we can have a more targeted approach to social distancing. But until we do that, we've got to hold the line when it comes to the basic public health measures.
Great. Well, thank you both so much for joining us, Steve Parodi and Polly Pittman, to talk about healthcare capacity and protecting frontline healthcare workers. Thanks to all in the audience who asked questions. I know we didn't get to everybody's question, but hopefully we can address some of those in future webinars. A recording of the webinar will be available on our website soon. So thanks again, and stay tuned for future webinars in this series where we will be addressing some more of the supply chain and other questions that have been discussed today. Steve and Polly, thanks so much again for joining us.
Thank you, Sarah.
Thank you.